assisting thorax respiratory system. Ask the patient to breathe normally as you observe him respiration. His respiration should be regular, symmetrical, and accessory muscle should not be used. While sitting with his arm at rest, move around slow to the patient's back as I do this. I will assess the anterior, posterior, and lateral thorax. Still standing behind the patients, use your finger pads to palpitate the spinous processes. They should be evenly spaced and done tender. They should be evenly spaced and non-tender. Assess the respiratory expansion. To do this, place your thumb at the level of T10 or the T10. Third vertebrae. Spread your finger, allowing for small folds of skin between your thumbs. Ask the patient for deep, slow breath as he does. Watch your thumb move with respirations. Their movement should be symmetrical. Breathe, sir. Slowly take a deep breath. Assess for the tactile primitus or voice sound palpitate on the chest wall surface. Using the ball of your hand, feel for vibration as the patients repeat the phrase 99. Say 99, sir.
99. 99.
Move from the apice inside the scapula down to the lower and lateral thorax. Each location you should feel equal vibration.
99. 99. 99. 99.
Perform mediate percussion. Use systematic pattern so you can compare two sides. Dissonance should be equal over the lungs. You should hear dullness over the diaphragm. Hyper dissonance means you found an area of increased air in the lungs or pleural space, as with the pneumothorax or acute asthma. Abnormal dullness indicates air in the lungs without build-up of pleural fluid. Assess his diaphragmatic excursion. Ask the patient to exhale and then hold his breath. Exhale, sir, and hold your breath. As he holds his breath, because from the scapula down there will sounds change from resonance. Mark the dull with the pen. Measure the distance, sit-off marks on each side. Normally, the distance represents the diaphragmatic excursion measures 3 to 5 centimeters and it's equal to both sides. Assesses the kidney. Using a blunt face percussion over the cause of multiple anger. Percussion in this should not be tenderness. Oscillate breath sounds with diaphragm of your stethoscope. Instruct the patients to breathe deeply through his mouth, starting at the lung apices. Osculate the lungs and move systematically from side to side, down to patient's back and laterally towards the axilla. Be sure to listen for that. At least one complete respiration at each location.
Breathe, sir. Breathe, sir. Breathe, sir. Breathe, sir. Breathe, sir. Breathe, sir.
Normal breaths should sound varied with the area you are assessing. You should hear bronchivascular sounds between the scapulae. These sounds are moderate in pitch and amplitude with an inspiratory phase is equal to the expiratory phase. You should hear vascular sound at the apices down the base, and then laterally these sounds are low pitch and soft with longer inspirational than expiratory phase. Listen for abnormal sounds such as cracks and wheezes, and for coughing and abnormal respiratory efforts. If you hear crackles and wheezes, ask the patients to cough and they listen again. To determine if the abnormal sounds have cleared, palpate the thorax. With the finger pads moving from the lung apice to the base, you should find no nodules and tenderness. Take a deep breath, sir. Okay. If you suspect an abnormality, have the patient say 99 as you escalate the S areas. Say 99, sir.
99. 99. 99. 99. 99. 99. 99. 99.
Assess the anterior thorax. Begin with the bones and muscle. Normally, they appear symmetrical and you should not see accessory muscle use, retraction, or bulge. The patients should not have signs of respiratory difficulties such as cyanosis or nostril flaring. Assess respiratory expansion. Place your hand on the patient's chest, along with the costal margin with your thumbs pointing towards the xiphoid process. Have the patients take a few deep breaths. Take a deep breath, sir. As he does this, watch your thumbs when you move simultaneously and symmetrically. Take a deep breath, sir. Assess for tactile premiers. As the patients repeat the phrase 99, move from the lung surfaces down to the point below nipple. Comparing sides permission, you should feel equal but stronger than the upper chest. Say 99, sir.
99. 99. 99. 99.
Osculate the patient's lung diaphragm with the stethoscope with the same pattern you use for percussion at each location. Listen for one complete respiration. Verbal breaths will sound vary with the area you're assessing. What happened? Breathe, sir. You should hear tracheal sounds over the trachea. These are high-pitched, loud, and tubular. You should hear bronchovascular sound laterally and over the bronchi at the of fluids. Expect to hear vascular sound over most anterior thorax and the periphery. If you speak an abnormality, have the patient say 99 several times as your escalate area involved. Normally, the words sound muffled and indistinct.
Ninety-nine. 99. 99. 99. 99. 99.